Good afternoon, and thank you for the invitation to be here today. And I must say that Rick stole my opening line, where I was going to acknowledge all those great nursing students that are here. There's 3 tables of them and their professor, and I think that it's really terrific that she brought them here. And I don't know if it was mentioned in my introduction, but I am a nurse, so. And I did get my flu shot, and when we go to that electronic record, totally, you wait and see what organisms those computer keyboards have on them. So I was invited to here today, as was mentioned, to speak about a paper that we had recently published. We've been doing extensive research, and I work at the Center for Health Outcomes and Policy Research at the University of Pennsylvania, where we primarily study nurses and what's happening in the work environment of nurses. And I wasn't quite sure, how I was going to begin this presentation, because I wasn't quite sure what type of audience we would have, if it would be primarily policymakers or stakeholders or physicians. But then I'm glad I chose the route, because we have those nursing students in the back, and I'm thinking that between all the clinical expertise they are gaining, maybe they don't have the opportunity to really study some of the policy issues that have occurred that have brought us up to this point where that we have this tremendous concern about the work environment of nurses. Healthcare went through a lot of transitions in this country in the 1980s and 90s, and as was mentioned in some of the previous presentations, the Institute of Medicine released a few reports that really had tremendous impact. And one of them, which was published in 1999, To Err is Human, caused a lot of controversy when all of a sudden it was made public that almost 100,000 people die a year in our hospitals from care, mistakes that have happened that are directly attributed to health care that's been provided to them. A couple of years later, the Institute of Medicine came out again with Crossing the Quality Chasm. They talked about deficiencies in our healthcare system, that we had to provide fundamental change, but they weren't quite sure yet of what the role was nursing in these issues. They didn't feel they had enough evidence to support any rationale for changing or addressing nurse staffing, and they called for additional research. Well, when we talk about nurse workload and patient outcomes, there actually is evidence in the literature. It's been there for about 2 decades now. And over again, we hear the same story from nurses. One, that there are not enough nurses in hospitals to provide quality care. There are not enough staff to help them get the job done. And they don't have enough support staff to at least allow them time to spend and talk with their patients. Back in 2002, colleagues in the center where I currently work published a paper that was in the Journal of the American Medical Association, which brought this even more of a highlight, and that's that, hey, when we begin to add patients to the nurse's workload, even one, we see dramatic changes. And our evidence showed that if you added 1 nurse to an existing nurse's workload, there was a 7% increase in the odds that the patient would die. A 7% increase that the patient would, die again, which is failure to rescue, and I'll explain that later. 23% chance that they'd have an increase in burnout, job-related burnout, and 15% increase in the odds that they'd be dissatisfied with their job. And this is a graph that just goes to show, this was from our study that was published in 2002, that just goes to show you. We had baseline as a 4-to-1 patient-to-nurse ratio, and each time, and on the vertical is the number of patients dying, surgical patients. And you can see, as you added 1 more nurse to a patient's nurse workload, more and more patients were dying. Well, then the Institute of Medicine came out with another report in 2004, and all of a sudden nurses are the highlight of that report. It was keeping patients safe, transforming the work environment of nurses. And they thought there were fundamental problems that threatened patient safety, and nurses if we addressed nurse issues, that we could address these safety concerns. They brought up nurse staffing, the number of hours that nurses were working, and mandatory overtime. We also had the Agency for Healthcare Research and Quality. They conducted a meta-analysis, and they found that there was an association between nurse staffing and patient outcomes. And then you have the Quality Forum, which now had to send the quality measures that they had devised, and now they were categorizing some of them as nursing sensitive, and CMS has devised a number of events. They're never events. Some of them are nursing sensitive. So you can see that people are starting to appreciate the role that nurses actually play in events that are happening within hospitals. I like to add a little humor once in a while. But I don't know how well you can see this from the back, my nursing students back there, but there's obviously an administrator taking an audit here of nurse-sensitive measures, and the nurses there saying there better be a line on that form for short-staffed, underpaid, and overworked to exhaustion measures. But all joking aside, California. When I mentioned earlier, and again to addressing the students that they might not know this background, in the mid to late 1980s, healthcare in the U.S. took some dramatic changes. We introduced a prospective payment system with DRGs. I'm sure you've heard of them before. And with the introduction of DRGs, the entire delivery system changed. We saw patients were sicker, length of stays were shortened. And I'm focusing on California because that was the gist of our research here, and that's exactly what happened in their hospitals. They found they reduced the number of beds in the hospitals. They were replacing registered nurses with unlicensed personnel, many of them untrained. Managed care had resulted in patients that were sicker. Their needs were more complex. They required intensive care, and they had fewer registered nurses providing care. Now, one thing that California has that not many other states do was the California Nurses Association, which has now become a national organization, National Nurses United, and they were going to fight to rectify this situation, and they fought hard. And in October 1999, California became the first, and is still the only state in this country that has mandated staffing regulations for every unit in the hospital. And these ratios were devised by the California Department of Health Services. The California Nurses Association was strongly involved, and that association was confident that this bill would, one, bring nurses back into the workforce, because they also found in this time period that only 40% of licensed nurses in California were working in hospitals, and that they would improve the quality of patient care. And these nurses were serious. They even took on the governor at one point. I don't know if you recall that, but they weren't the best of friends with Arnold Schwarzenegger. And they had taken out billboards that they plastered all over California. They took a full-page ad out in the New York Times because he threatened to alter these ratios. And the nurses won. But AB 394, which has been recognized nationwide, and many policy groups and stakeholders have been examining this bill. And I just took two quotes from it, and it was, "This bill would prohibit a general acute care hospital, an acute psychiatric hospital, and a special hospital as defined from assigning an unlicensed person to perform nursing functions in lieu of a registered nurse." This bill would also require the department, with regard to general acute care hospitals, acute psychiatric hospitals, and special hospitals, to adopt regulations that established certain minimum nurse-to-patient ratios. And that's their law. It goes on and on for pages. So this has been catching on, and there were a number of states, 15 as of recent, the American Nurses Association has posted on their website, 15 states and the District of Columbia have enacted some type of nurse staffing regulation. Of course, they vary. There's no consistency. Some have staffing plans where they have a staff nurse on a team that helps develop what they think meets their acuity. Other states have disclosure or public reporting of their staffing ratios. California is the only state that has this mandated. And of course, it's a very contentious issue. especially with hospital associations, because it costs the money to hire more nurses. However, if they'd sit down and actually research on the cost that they spend on adverse events, in the long run, it would not be costlier for them to be hiring more nurses if it meant preventing adverse events. So what we thought here in our research center at Penn was, well, California has these mandated unit-specific staffing ratios. They kind of present a natural experiment. Because if you were doing research, there was no way you could go into a hospital and say, listen, we're going to manipulate your staffing levels for a year and see what happens. So here we had it. We had California with the mandated staffing and other states that don't. And we wanted to know if we could find, did this staffing really produce a favorable change? And there had been no research on patient outcomes since the legislation. There had been some studies that reported on it and whether facilities were complying, but there was no good research on patient outcomes. So what we did is we used California mandates as a benchmark. We compared nurse-to-patient ratios in California hospitals to other states, 2 of them, New Jersey and Pennsylvania. We examined the potential consequence of California legislation, meaning their nursing skill mix, because the California law just gave specific nurse-to-patient ratios, but it didn't say registered nurse. So in California, they could actually use LVNs or licensed practical nurses to meet those ratios. We compared outcomes for nurses and indicators of quality of care, and we compared 2 patient outcomes, that being 30-day inpatient mortality and failure to rescue. The backbone of our research at Penn is nurses, as I'd mentioned, and we survey registered nurses, hundreds of registered nurses. So we have data from nurse surveys that are unique to our center, and no one else has them. We also have data from the American Hospital Association annual survey, and we have patient discharge summary data from the 3 states. In California, that's the Office of Healthcare Planning and Development, the New Jersey Department of Health and Senior Services, and the Pennsylvania Healthcare Cost Containment Council. And we had data on all patients admitted to hospitals in those states. We used adults that were 19 through 90 years of age. When we surveyed our nurses in the 3 states, we obtained a list from the state licensing boards, which gave us an address of every nurse actively licensed in that state. We took a random sample of those nurses, and when I've spoken in the past to people that I know that do survey research, when I told them we surveyed over 200,000 nurses, they just sit back and they shake their head and they said, the federal government doesn't even survey 200,000 people, but if you think you can do that, fine. So we had a random sample of 40% of all licensed nurses in California and Pennsylvania and 50% of all licensed nurses in New Jersey, and those differences only were because of funding issues. And we mailed the surveys to the homes of nurses. We don't go to hospitals because we feel the hospital might have the option to back out, or that nurses might feel that somebody within the hospital would be able to see their responses if we sent surveys there, so we mail them to their home. Knowing that non-response is a big issue, and our response rate wasn't the best for a number of reasons, it was around 36%, we did a non-responder study to assess non-response bias. So we took a sample of 1,300 nurses who did not respond to the original survey. 91% of them returned it. And we found out that there really wasn't much difference between the nurses who completed the original survey and those that didn't. There were a few demographic differences, most of them being international nurses that were a little hesitant to reply. But the items that were of interest to us, all the aspects of the work environment, there was no difference between the 2 groups. So we felt very confident with our findings. Our nurse survey contains questions. It's a 12-page survey, if you've ever received one, on demographics. I've listed a few: their age, sex, their educational attainment, their years experience, how many years they've worked in their current hospital, how many years they've worked on their unit. We assess burnout using the Maslow Burnout Inventory Human Services Survey. We question them on job satisfaction, their intent to leave. We use the Practice Environment Scale of the Nursing Work Index to measure aspects of the work environment, and we ask them a battery of questions on the quality of care. From the AHA annual survey, we use 3 hospital characteristics. Bed size, and you can see we stratified them into small, medium, and large. Teaching status, or the ratio of residents to beds, where we had non-teaching, minor teaching, and major teaching hospitals. And technology status, that's defined as open heart surgery, organ transplant, or both. Our patient discharge summary data, our inclusion criteria were general, orthopedic, and vascular surgery patients. Now, we pick surgery patients because they have to be fairly healthy to be undergoing surgery. If you choose medical patients, they may have many underlying different conditions that we wouldn't be able to assess through administrative data. So we pick these 3. We also choose them because they're the most common surgical procedures, and they performed in almost every hospital. We select them based on ICD-9 codes. We risk adjust all our patient data, knowing that some patients will be sicker than others. So to give each hospital being on an equal playing field, we risk adjust the data based on ARC's Elitzhauser comorbidity index. We risk adjust them on age, sex, transfer, admission type, and 130 other comorbidities that would be too long to answer or present right here. Our outcomes of interest are twofold. They're nurse outcomes and patient outcomes. We're interested in nurse job dissatisfaction, job-related burnout, and intent to leave. Patients, as I had mentioned earlier, 30-day mortality and failure to rescue. Now, failure to rescue is a catchy little concept that's been of interest and used throughout the literature. It's not often defined as it was originally meant to be. Failure to rescue was a concept that was designed to be applied only to surgical patients, and it's defined as death following a complication in care. So it's basically 2 types of mortality that we look at. Our final sample for this analysis, because we want to just bedside nurses. Of course, when we have that licensing sample, you wouldn't believe how many nurses are like 90 years old and still have a license. So we want to adjust those. We lose a lot, even though we sampled almost 250,000 nurses and 36% or so sent them back. Till we trim them down, we have no way of knowing where they work until they tell us, because in our survey we do ask them to identify the hospital where they're employed. The sample for this analysis was 22,366 nurses, which is still a sizable number of registered nurses. We used data on a little over 1 million patients, and these nurses and patients represented 604 hospitals in the 3 states. And just so that you know that we do some serious statistical analysis. We pay some great statisticians to help us. They did do multivariate analysis. They controlled for, like I said, 130 patient-level characteristics and nurse characteristics and hospital characteristics. They do a great job. So this is what we found. And this is the mean hospital workloads by state. That in California, nurses staffed at or below the level mandated by legislation. And we would hope because hospitals can be cited in California. I don't know exactly what the fine is, but they can be cited for not complying. That's 24/7. So if a nurse goes out on a break, there has to be a relief nurse to come in and replace her. The hospital mean in California was 4.1 patients per nurse. And the medical surgical mandate for California law is 5-to-1. We found in our study that the mean was 4.8. In New Jersey and Pennsylvania, when we looked at all unit types, they all staffed higher than the California ratio. Workloads were higher than the California. Yeah, I said that. Okay, sorry. The hospital mean in those 2 states was 5.7 or 5.4 patients per RN. In medical surgical units, it was 6.8 in New Jersey and 6.5 in Pennsylvania. And this is the average workload reported by hospital nurses by unit type. You can see the second column has the California mandate, and you'll notice that all the California, when we look by unit, all the units are within compliance, and those hospitals in New Jersey and Pennsylvania are all staffing above that California mandate. Because the California ratios are unit specific, I thought I would go into some detail on what these nurses were saying on the units. So medical surgical nurses, the California mandate is 5 patients to a nurse. And we asked, well, we computed the percent of nurses reporting staffing at or below that benchmark of 5.1. Well, 88% of the California nurses said that they were staffing at that level. I don't know why it's not 100%, but 88% of them, med-surg nurses, reported that. 19%, only 19% of New Jersey nurses stated that their med-surg units were staffed at that level. And 33% of Pennsylvania nurses reported staffing at that level. When we looked at the data from pediatric nurses, California mandated ratio is 4 to 1. And I should clarify, these were the ratios in 2005-06 when we acquired these data. These ratios have even improved further in California. The percent of nurses reported staffing at or below the California benchmark at 4.4 patients per nurse. 85% of the California nurses stated they were in compliance. 52% of New Jersey nurses and 66% of nurses in Pennsylvania. Telemetry nurses, the mandate is 5 patients to 1 nurse. Those reporting to staff at or below that benchmark, 93% of the nurses in California, 35% of the nurses in New Jersey, and 52% of the nurses in Pennsylvania. Oncology nurses, the California mandate, 5 to 1. The percent of nurses reporting staffing at or below that benchmark, 90% of nurses in California state that they staff at or below that number. Only 23% of nurses in New Jersey staff at that level. And 55% of nurses in Pennsylvania report staffing at or below that mandate. Psychiatric nurses, the California mandate at that time was 6 patients to nurse. And again, the percent of nurses reporting that they're staffing at or below that benchmark, 81% of the nurses in California, 56% of New Jersey nurses, and 42% of the nurses in Pennsylvania. Intensive care nurses, and we would think this would be kind of consistent, and I'm surprised that the percents are a little higher because intensive care units typically have a ratio of 2 to 1. Only 85% of the California nurses said that they were staffing at or below the 2 to 1 requirement. 63% of New Jersey nurses and 71% of Pennsylvania nurses. When we looked at the survey results from labor and delivery nurses, the California mandated ratio is 3 patients to nurse. And when we asked again the percent of nurses reporting at or below the benchmark of 3 to 1, we found that 94% of California nurses reported staffing at that level, 88% of New Jersey nurses, and 89% of Pennsylvania nurses. Well, I mentioned a few minutes ago, one of the concerns with the California law was nurse-to-patient ratios, and it didn't say registered nurse-to-patient ratios. So we asked the nurses in California how things had changed on their units, hoping that we'd find a little bit more detail on what happened with these compliance issues, because we were concerned. We're hospital staffing with more LVNs rather than RNs. And when we asked California nurses about patients assigned per nurse, 42% of nurses reported a decrease in the number of patients assigned to them since the legislation. 15% of the nurses reported an increase in the use of LVNs, so that was reassuring. In fact, 25% of the registered nurses reported a decrease in the use of LVNs. 34% of nurses reported a decrease in the use of unlicensed personnel, and 30% of nurses reported an increase in floating, and 34% of nurses reported an increase in the use of agency nurses, which wouldn't be surprising because they had to somehow meet these mandates. Well, we asked nurses about environmental characteristics, and the percent of nurses agreeing with the following that were present in their job, and one of them was reasonable workload. We asked them, was their workload reasonable? 73% of California nurses reported it was reasonable. 59% of New Jersey nurses reported a reasonable workload, and 61% of Pennsylvania nurses. We asked if they had adequate support services to allow them to spend time with patients. 73% of California nurses agreed with this, 59% of New Jersey nurses, and 61% of nurses in Pennsylvania. When we asked if there were enough registered nurses on staff to provide quality care, 58% of California nurses agreed that there were, 41% in New Jersey, and 44% in Pennsylvania. When we asked them if they had enough staff on their unit to get the work done, 56% of California nurses agreed, only 40% in New Jersey, and 44% of nurses in Pennsylvania. Then we looked at the effects of increasing workloads. And when we actually looked at the hospitals, that cluster of hospitals that were least likely to comply with the California mandates. So if the workloads were increased, we found that there was a 20% increase in the odds that they'd have complaints from patients or families. That there'd be a 30% increase in the odds of verbal abuse by patients or staff. A 50% increase in the odds of burnout, 50% increase in the odds of job dissatisfaction, a 60% increase that the work environment would be rated as fair or poor, an 80% increase in the odds of quality of care as fair or poor, 50% increase in the odds that nurses would report that their workload causes them to miss changes in a patient's condition. This is very important for failure to rescue, the complications. And 60% increase in the odds that workload would cause them to look for a new position. So this is very appropriate in an era where nurses are overworked. So the patient's looking over to the other bed and says, "You don't look so good, should I call the nurse?" And of course, there's the nurse in the other bed. So we asked California nurses a few more questions on aspects of their jobs since the implementation of the mandated ratio. 34% reported fewer patients in their care assignments. 71% of the California nurses stated that the quality of care has improved since mandated ratios were introduced. 65% report that their workloads have been reduced. 64% say nurse retention has improved. And 60% believe that nurses outside of California are more likely to come to their state to work. When we looked at 30-day inpatient mortality, so these are the odds that patients would die based on workload. We determined that if you added one additional patient to a nurse's workload in California, that there was a 13% increase in the odds that a patient would die after adjusting for everything, all the other nurse, hospital, and patient characteristics. If you added one additional patient to the workload of a nurse in New Jersey, it increased the odds by 10% that a patient would die. And when you added one additional patient to a nurse's workload in Pennsylvania, there was a 6% increase in the odds that patients would die. When we looked at failure to rescue, we found that adding one additional patient to a nurse workload in California increased the odds of failure to rescue by 15%. When we looked at nurses in California and patients, we found that adding one additional patient to a nurse workload in New Jersey resulted in a 10% increase in the odds of failure to rescue. And adding one additional patient to a nurse workload in Pennsylvania increased the odds of failure to rescue by 6%. And these were all statistically significant findings. And I should have mentioned that earlier, too, with all those comparisons of nurses reporting in compliance and such, there were statistically significant differences where California always looked better. So in conclusion, nurses in California cared for one fewer patient per shift than nurses on comparison units in Pennsylvania and New Jersey, 2 fewer on medical and surgical units. Most California nurses had workloads in compliance with the California benchmark, But only 19% of medical surgical nurses in New Jersey and 33% in Pennsylvania had workloads at or below the limit of 5 patients each. Nurse burnout, job dissatisfaction, intent to leave were significantly lower in California hospitals than in the other 2 states. And if nurse workloads in Pennsylvania and New Jersey were reduced to the levels in California, surgical deaths would be reduced by 11% and 14% respectively. I wanted to end with this picture. Maybe I should have put it up originally. They say a picture is worth 1,000 words. And we could have just left it there and I wouldn't have had to say too much. But over and over today we've heard about about quality of care. And we know that patients are sicker and care is more complex. And when I look at and this is not an actress. This is an actual photograph. This photograph was a prize-winning photograph in the American Journal of Nursing a few years ago when they had a contest asking nurses to submit photographs of their workplace. And can you imagine, just look at the complexity of this situation here. And then you add to a nurse's workload. You can see why adding one additional nurse to a work like this would result in increased mortality. One patient. Yes, we could add more. Yes, you could see with a complex situation like this, if you had a nurse that called out sick, and this specific nurse had to take care of another patient who was equally ill, you can see how mistakes happen, how you have failure to rescue, because complications are missed. And hospitals don't have the opportunity. The nurse is the one who's at the bedside 24/7. They have to be the eyes and ears of other providers. They have to be the key to failure to rescue. They have to recognize complications when they occur, and they have to be able to access the resources in a timely manner to rescue patients.